So for those who don't know me, I'm Frances Hines. I'm the RD&I manager for NHS Highland. And what we've been doing is writing up this toolkit. And before I start, I will say what we do generally for all of our projects is try to create something that's actually useful and pragmatic. Lots of European funded projects end up being rather theoretical and ending up on a shelf, but we absolutely want to make things that are useful. So any comments as we go through or at the end, I would be really happy to receive. Right, let me see if I can get this to work. Okay, the way I always think about non-clinical IoT is a bit like an iceberg. So the clinical IoT, the sexy stuff that everybody thinks about with the NHS, for example, doctors, nurses, patients, and all that malarkey, is above the water and is obviously extremely important. But actually, when you come into a big organisation like an NHS health board or trust, there are more people under the water doing things than above the water doing things. And without this under the water activity, the stuff you can see above the water wouldn't happen. And it includes things like estates management, transport, energy, e-health, waste management, water management, procurement, sustainability, asset management, and there are many, many more. That's just some of the sort of big areas. And when we're talking about non-clinical IoT, we're not saying that there might not be an impact on clinical IoT, or it might not even, it might be a combined project with both clinical and non-clinical outcomes. But what we're really focusing on are these non-clinical activities that can benefit from IoT input. So what are we actually thinking of? It's a bit of an odd word, not really sure how we ended up with it in terms of being an IoT strategy. And I think in this context, we're saying a strategy is a plan that identifies technology related to IoT, however that's defined within an organization, that will help to achieve improvements, and in our case, improvements in non-clinical systems. And I would say that maybe two of the main components are that you need to think strategically about this rather than what often happens in the health service, which is identify a problem, have a bit of a knee-jerk reaction, spend a bit of money and hope it's going to solve it. That's not really the kind of way we're encouraging people to think. What we're basically saying is let's think at a system level, let's think at more than 1 year hence, maybe 5 years hence or 10 years hence. What can we use IoT for in a large scale over a long period of time to achieve large scale benefits? So strategic thinking is one thing, and it's about delivering the service. And we deliberately didn't just stick this with health service. I mean, any public body, whether it's local authority, whether it's the police, whatever it is, it's the same kind of issue. Everybody has you can call it non-clinical or maybe non-client facing, non-front end, whatever you want to call it. It has that kind of activity going on somewhere, and really whatever you do in one public body should be transferable to another. So delivering the service is the key thing. So what are we including in this document when we can send it out to you? So these are the main components. We put a little bit of background into it to explain why it's important. We talk about mapping the organisation, working out what issues and gaps face the organisation wanting to use IoT, thinking about what existing structures, either in the organisation or external to it, might be useful to provide innovation support. Identifying and working with stakeholders in the organisation and external to the organisation, because if you don't get people on board, it will fail. Developing an actual strategy, a strategic way of thinking about non-clinical IoT, using a test bed, which you might not consider to be appropriate for every project or everything that you're thinking about, but using a test bed, some guidance and process about doing that, evaluating how the test bed went. The NHS, for example, and I'll just say that's the NHS as a whole across the whole of the UK, is pretty bad at evaluating how things perform, projects or whatever it is. We're quite good at spending money on doing stuff, but we're generally not as good at evaluating how things went. And then a little bit on next steps. You know, what can you do next? What are you going to scale it up, get more money? What are you going to do? So in the strategy document, these are the sections, and I'm just briefly going to go through each one and say what we have included in each one. And it's things like, in context and background, you know, what is your organization doing for the next 5 to 10 years and why? And in NHS Ireland, we've got some good examples in that, you know, having come through COVID, we've, as an organisation, written more than one remobilisation strategy. There is a lot of strategic planning going on. And a lot of what we're doing is divesting activity, i.e. patient activity, from our main hospital, which is in Inverness, out to the other smaller hospitals or to GP practices or to patients' homes or to community hubs. That was already happening a bit before COVID, but oh boy, has that speeded up. And we're doing it for all sorts of reasons, which you might imagine, but one of which is to sort of reduce costs, reduce carbon impact, and so on. So, you know, that's just one thing that we as an organization have got as a strategic plan over the next 5 to 10 years to divest patient activity, unless it is truly acute, out of the main hospital and to the other areas of the region. And our region is the biggest NHS region in the UK. It's bigger than Belgium. So you can see that we have a lot of non-clinical IoT issues that will uh, bear some intervention from IoT, whether it's managing the 103 buildings on our estate, or whether it's looking to reduce our carbon from travel, or whether it's reducing pollution into water, or whatever it is. So another question to ask yourself when you're one of these big organizations is, why are we considering IoT as a set of solutions? Is it the best way to go? You can't just always assume that by doing a particular set of technologies, that's the best way. And a third thing you really need to think about are, what are your motivators and inhibitors in going down this road or going down this route? Because sometimes the barriers are so huge that you might decide that now is not the time to start thinking strategically about this. Somebody described to me 15 years ago when I started in NHS Ireland that the NHS is like a dinosaur. And if you're at the end of the tail, which we are in RD&I often, although we're slightly better than we used to be, we could do anything we damn well pleased, because by the time it got to the head, you know, everything would have been sorted out, because it takes such a long time for the NHS to change how it does things. I think that's changed a bit. Maybe we're a slightly smaller dinosaur or a slightly quicker running dinosaur than we used to be. But it still holds true, and it is true of any big organization. So another section is thinking about mapping the organization. And I think, you know, I would say three key things in thinking about IoT, non-clinical IoT, you need to understand where the organization is going, talk to stakeholders, the health board, people on the board, look at existing strategies, remobilization plans, what government strategies there are for this public body, what policies there are. That actually takes quite a bit of time, but it might be that somebody's already doing it in the organization, but you have to know the context in which you're setting things. I think you could usefully map any other or any existing IoT activities and evaluate where they are. So, I've put a little example of a spreadsheet you could use to sort of say, where you've got to with something and how successful you think it is, and work out what opportunities there might be and try and put it together to make sense. The mapping diagram that I've put there is, just a standard kind of mapping diagram to say these are all the sort of separate sections you're going to get in a big organization, and if it's useful to break them down, then that would be something you could do. And if you can identify individuals to help you, then you've got your stakeholders identified. So for example, in the estates department of NHS Highland, there's something like, I think it's nearly 3,000 people working in estates. And obviously, you can identify the people at the very top, but sometimes it's not those people who you're going to try and engage with. So spending a bit of time trying to get some kind of map of the organization is useful. In NHS Ireland, there is not one map. There are many maps, and they're rather out of date because by the nature of things, they go out of date very quickly. But it is useful to do something like that, I think. I think you need, as an organization, to really be realistic about what issues and gaps there are and whether there are barriers. And here's only 6 things that we've picked out. A lot of these came out of the workshops, of people saying these are barriers. So they could include, for example, data security issues. That is, the headache that we are all constantly having to think about. Thinking about stakeholder issues, internal stakeholders, as I've just said, staff on the ground need to be engaged for solutions to work. It's no good trying to impose things. It will fail. And in the NHS, we have many examples of failure. But there might be legacy issues, stuff that's happened in the past that would put up a barrier to trying to change how we do something from a technology viewpoint. Cost is always an issue. So, I think what you have to do is, if you can identify these issues, you then have to run them through some kind of risk assessment to work out whether the risk that they pose is so huge that you cannot progress what you want to do, or that you can work out that there are a number of relatively low risks that can be overcome. And that is something else that I think needs to be done to justify developing your non-clinical IoT strategy and the projects that follow it. Nothing happens in public bodies without proper business cases, and that's true of the NHS. I think also looking to see what actually happens in the organisation, what existing support is there in the organisation, or what external support is there, what innovation organisations there are. I mean, we've been working with Census on this project, and they've been extremely helpful. So in our case, that's just one organisation, external business organisation, if you like, that has been helpful. But there's all sorts of networks and organisations out there, and it's trying to find out who they are, and how useful they are, because you can end up with being frankly swamped with help and you've got to be a bit robust about deciding who are the best organizations or people to help you, rather than getting sort of diverted off into spending a lot of time and coming out the other end with something that's not particularly useful. Thinking about your stakeholders. What stakeholders are there? You know, are patients likely to be impacted or involved? Are doctors and nurses and others likely, or is it going to be more likely to be, you know, admin, IT, management staff, people from estates and facilities, R&D and innovation, departmental heads, directors, network providers, and you know, you could have a huge list. Again, you need to sort of be a bit robust about it and think exactly who these people are and how are they likely to be impacted and engaged. And external stakeholders, you know, there's always a lot of interest about what is happening. And just from our experience in RD&I, we know that as soon as we start working on a project that may be non-clinical IoT or maybe involve that and something else, then the Scottish Government is likely to be interested to find out. And even when I mentioned that we've been doing this stuff at an innovation group for the north of Scotland the other day, a couple of the other health boards were interested, because, you know, if one health board, for example, does something and proves something, then other health boards will immediately be interested. And the reality is that practically every health board and trust in the UK is going to have the same problems. And how well do you communicate with your stakeholders? Because that is something, you know, if you're not good at communicating with them, that can lead to sort of instant failure as well. So this will blow your mind. If you do something called social network analysis, what you actually do is plot everybody you relate to, and then you do different thicknesses or numbers of lines between you and the people you relate to. So that is probably one of the most complex ones you might find, but it's quite useful because it determines who are the people you talk to most and are they the most useful people to talk to. So what I've actually said is that smaller one is probably a little bit more likely, and doing that, spending that time looking at interactions allows you to identify which stakeholders you already know, identify the strength of your relationships and what they're based on, work out how likely they are to be engaged and whether they will be very accepting of the project or accepting the idea of change. Again, you know, in the NHS, some people have worked for the NHS for 35 or 40 years, and by this time, they probably having substantial change is not something they want to think about. So you have to take those perspectives into account. Work out who you don't have a relationship with or have a weak relationship with. Work out why you don't have a relationship and does it pose a threat to the project, and work out what you need to do to strengthen or manage that relationship. And you cannot underestimate how important those relationships are. A bit like evaluation. You know, people talk about it a lot, but they don't really spend a lot of time looking at it and supporting it. And weak relationships lead to often poor outcomes. So, you know, those are all sort of preparation-y things that would be done by the public body that would but would also include relationships with external bodies and maybe SMEs or business bodies as well. So, you know, it's not just a one-way street, but a lot of this is about the preparation within a public body that is seeking to deploy non-clinical IoT. So if you're developing a strategy, like I said, it can't really just be project by project by project, because that's got to fit into a context. Otherwise, how are you being strategic? So you need to think about within your strategy document to relate it to the organizational strategy or remobilization or whatever it is. And you need to integrate that strategy into the needs and requirements of the organization and all the separate departments. So, you know, if you know the context in which you're working, you will be able to write an more easily write strategy. It has to be time and resource related and underpinned by business planning, not only of the whole organization, but maybe of the separate departments. And it should include aims and objectives, expected outcomes, milestones, time schedules, resources, and so on and so forth. It's got to be well planned. And as I've mentioned a couple of times, it, you know, the NHS, love as much as I love it, and like working in it, is not always very good at doing that kind of development. What tends to happen is an issue arises, and to try and address the issue, a bit of money is poured into it, something happens, and it's hoped that that sorted that issue, but actually it might be addressing the symptoms rather than the causes of that particular issue. So this is sort of one strategy that we in RD&I have put together for clinical and non-clinical IoT to try and see, you know, where we're going with this. IoT is one of our innovation section cluster areas, strategic cluster areas. So what we're doing is saying, well, over the next 10 years, what are we going to be doing with IoT and how can we support it? So these are the kind of things that make up our strategy. And you don't need to write a huge wordy document. To me, if you can put a strategy together in relation to one diagram, then job done. But it shows you how it all fits together, and it's easy enough to change. If you want to operationalize the strategy, well, I'm not going to tell people how to do that. And that's why I've said it's a bit of grandmother's sucking eggs, because, you know, if you write a strategy, you will have different ways of putting that into operation. I mean, we tend to use lots of project tracking, schedules, deliverables, outputs achieved, reporting and process kind of activities and documentation. I think the key thing to say is however you do it, it acts as evidence and it should be auditable and it should be accurate and it should be transparent and available to anybody in the organisation who needs to see it. So having done your strategy, you might then decide to try and address an issue or a problem by doing some form of test bed. You do not have to use a test bed. You know, you can basically go, well, actually, we can see the problem. There's a product that somebody's already got. We'll buy the product and we'll just use it. And yeah, it's a perfectly valid way of doing things. However, sometimes, and quite a lot of times, because public bodies don't have solutions, they are not really clear as to how well a solution might work and what the problems might be. So test beds are, and there's a couple of definitions here, identified as involving the NHS working with innovators using technology to address complex issues facing patients and the health service. So that's for all sort of technology. Or NHS organisations and industry partners being brought together to test combinations of digital technologies with pathway redesign in real world settings. So the same kind of thing, slightly differently said, and specifically in Scotland, allowing innovative solutions to be tried out in a real world environment and to ensure that they are fit for purpose clinically, financially and operationally before being brought into wider use in the NHS. In other words, before being brought into procurement. So that's sort of essentially what a test bed is. And what we are basically saying in this strategy is that we're being pragmatic. Using a test bed for non-clinical IoT projects allows us to develop and or test and or scale up products or technologies or solutions with companies to sort out problems. And here we have, if you like, the continuum between the public body, the NHS, and how companies can help us address all the issues we've found out in our preparation to get to this point. So, you know, we need, and again, a lot of this has come out of the stakeholder meetings that we had, the focus groups. We need to understand how the test bed and the solution fits into the whole of non-clinical IoT context. In other words, conducting some kind of systems analysis, which, as I've said, is vital if the outputs of the test bed are to be acceptable to staff. Focus on one important and feasible pilot, make sure that it's successful in some form or other, because if you keep trying things out and they keep failing, then when you go back to staff, they will not engage and it will become ever more difficult. Have the capability, resources and funding to run a non-clinical IoT test bed to check that the proposed solutions are likely to be viable and smart. Make sure that there's minimum disruption of existing services and job loads. It's no good going to people and saying, oh, we're going to do this, and by the way, I want, you know, 5 hours of your time a week. That's not going to happen. You know, in our division, we are fully aware that if we want to test something out, we have to make it as accessible and non-impactful on the jobs of people working in hospital or wherever. Get buy-in and ownership from non-clinical teams, engage with procurement to comply with procurement regulations and guidelines. And we work directly with procurement in NHS Highland to support procurement from SMEs once successful test bedding has taken place. And make sure that evaluation is part of the process. As I said previously, many projects, pilots and test beds fail or do not achieve the required outputs because that aspect is so poorly done or not done at all. And frankly, I do get a bit fed up with people ringing me, you know, hysterically going, oh, we've just spent all of this money and we didn't think to evaluate it. And now somebody's asked us how successful it's been and we don't know. And so one of the things we are suggesting that we're doing within this project is to provide templates to actually do the test bed. So we're providing documents and we still haven't quite decided whether they're going to be electronic or paper or both to help people in the public body, but also companies that may well be working with you to look at doing a test bed to answer these questions. And there are a whole bunch of separate documents that allow you to, you know, gather that data to then decide exactly how you are going to do that test bed. And it might be that you, for example, having described, quantified and prioritized what a particular problem is that may be suitable for a non-clinical IoT solution. You know, we then do a technical review to confirm that. We do a resource review to confirm whether we've got the resources to support it. You identify the stakeholders, you engage with the stakeholders. And again, we're providing sort of questions and documents to allow you to run that through. And then developing the actual test bed product. So we're providing templates for project plans, for methodologies, for governance, for example, for information governance, for costings, or anything that you would need to use to put a test bed together that, frankly, at the moment, sometimes is a bit less well or less robustly developed. And we are also giving people the sort of evaluation documentation and the processes that you need to do to evaluate things properly. So that's a sort of explanation of what we are providing along with this document to help people do test beds if they want to. And briefly, thinking again about the evaluation process, you need to think what you're evaluating, why you're evaluating it, the points at which you are carrying out data gathering for evaluation, at minimum baseline, midpoint and end, how you're evaluating, what processes you're using, what data you're gathering, and how you're measuring the evaluation. And here's some examples. You know, you could use health economics, cost benefit analysis, financial flows analysis, value for money assessment, return on investment. You know, there's a whole bunch of things. So you do need to build that into whatever you're doing. And I think you have to make it clear both to yourself and to the companies who you are working with that that is very much a key part of determining how successful the outcome is and what's going to happen next. And finally, in the strategy document, we briefly talk about what you are going to do next, scaling up. Do you want to do more testing? Do you need to get funding to do a bigger project? You know, or are you going to go down the early recruitment process for inclusion into NHS, which you know, is not the easiest thing to do. So we're putting in the information in how to engage with NHS procurement as a next step as well. And that's me. So I've talked at you fairly continuously for 23 minutes